Hi, everyone. My name is Beatrice. I'm a statistician working with Lorna at the Health Services Research Unit at the University of Aberdeen. And it's my pleasure to introduce Brennan Kahan today. So thank you for accepting our invite, Brennan. Brennan is a statistician and a senior research fellow at the University College of London. And I could highlight a lot of the contributions he has done to trial methodology, but two of them that he has led a lot of work on are related to re-randomization designs in clinical trials and estimands that he's going to touch on today. And one thing that I wanted to highlight, Brennan, is your recent paper on estimands in COVID-19 trials and making sure we're asking the right questions. So I think this is of interest to everyone here. Thank you, and over to you.
Thank you. Well, thank you for having me. So I'm going to be talking about estimands and how we can use estimands in randomized trials to make sure that we're answering the questions that we want to be answering in these trials. So I'm going to go straight into a motivating example for why estimands can be useful. So I came across this trial a little while ago. This was a trial looking at whether this new drug improved quality of life in men with metastatic prostate cancer, and they found that it did improve quality of life by a decent margin. This is quite nice to see. A lot of the cancer trials I see either don't report quality of life outcomes, or they find new interventions might actually decrease quality of life due to toxicity and those sorts of things. So seeing an intervention would actually improve quality of life is quite exciting. When I read this paper, I kind of assumed that the interpretation of this treatment effect means that if we give men with metastatic prostate cancer this new drug, it will, on average, improve their quality of life by 0.08. And I think most people reading this paper would come away with the same impression. But this isn't actually what this treatment effect means. It means something a little bit different. And what it means is this figure, 0.08, this is an estimate of what the treatment effect would be in the hypothetical scenario where men with metastatic prostate cancer never experience disease progression and never die. So let's just unpack that a little bit. So this new drug, this is given specifically to prevent disease progression and death. So what this treatment effect is saying is that if participants don't experience disease progression and don't die, so they don't actually experience the things that this drug aims to prevent, then this drug would be useful in improving their quality of life. So if patients don't need this drug, then giving them this drug could be useful. So I think it's debatable whether this treatment effect is clinically relevant. I won't say it definitely isn't. There might be kind of reasons why this is useful. But I think clearly understanding what this treatment effect represents is essential to understanding and interpreting trial results. If you're a patient or a clinician kind of deciding whether to take or to prescribe this drug, or if you're a member of a NICE committee deciding whether to pay £20,000 or £30,000 per year or however much this drug costs, I think understanding that the treatment effect reported in the paper applies to kind of a hypothetical setting that doesn't really exist in real life may not necessarily change your decision, but I think that information will influence that decision a little bit. Now, the issue is that patients, clinicians, people from NICE probably won't actually know what this treatment effect represents. They won't know that this is the quality of life improvement if people with metastatic prostate cancer never progress or die, because that's never actually stated in the manuscript. The manuscript kind of says we'll compare quality of life between groups, and this is the statistical methods we're using to do that, but they don't kind of explicitly say what that means. And the reason we get this slightly odd interpretation in our treatment effect, it's due to a couple of quirks of the study methods. So they measured quality of life several times during the trial, so every month or so. And what they did is after patients experienced disease progression, they stopped collecting quality of life and set that data after disease progression to missing. And of course, after patients die, they don't have a quality of life, so that's also set to missing. And then the investigators used a repeated measures mixed model, which implicitly imputes missing data. So in this case, it implicitly imputed what the patient's quality of life would have been after patients had patients been alive and not progressed. So because of these kind of two different study choices, you get this slightly odd interpretation in the treatment effect. One of the problems here, though, is you don't understand these quality of life results unless you have some sort of detailed knowledge or understanding of kind of how repeated measures mixed models work or how advanced statistical methods work. And I think it's fair to say probably a lot of stakeholders or people using trial results, like patients, clinicians, won't necessarily have this understanding. I mean, the reality is I think a lot of statisticians won't necessarily intuitively understand this sort of thing, just because it doesn't really come up very often. So part of the issue, and this isn't a general issue specific to this trial, I think this is an issue that's a much wider issue, and it's that there's a lot of focus on statistical methods. So we have to kind of write out what statistical methods we're using. But these statistical methods really only tell us the methods we're using to answer the question. They don't necessarily tell us what the question is itself. So if you kind of walked in and saw me with a hammer, some nails, and some wood, you might know that I'm building something. You might know the tools that I'm using to build that, but you won't know whether I'm building a cabinet or a counter or something else. And it's the same with statistical methods. Knowing kind of that we're using a repeated measures mixed model tells me how I'm answering the question. It doesn't tell me what it is I'm actually trying to estimate or what the question is. And so that's where estimands can be helpful. So an estimand is just a description or a precise description of the treatment effect that we want to estimate from our trial. So it's the question that we're trying to answer. And the important thing about the estimand is it's separate to the method of statistical analysis. So it's separate to how we're trying to answer the question. And so using estimands, kind of explicitly describing the questions that we're trying to answer in these trials and the treatment effects that we want to estimate, can make sure that everyone understands what the question is that's being addressed. It makes sure that we can look at whether that question is useful. And it can also make sure that we are able to kind of choose the right study methods, data collection, and analysis to kind of robustly answer that question. So in short, I guess the purpose of estimands is really about making sure trials give themselves the best chance of kind of meeting their objectives and providing useful information for stakeholders. So an estimand, it's made up of 5 different aspects. So the treatment conditions being compared, the patient population of interest, the endpoint, population level summary measure, so how outcomes between different treatment conditions are being compared, and strategies to handle intercurrent events. So I'll just go through each of these aspects quickly and explain a little more about what they mean. So treatment conditions, so these are basically the treatment groups we want to compare within our trial. And it's important to note this won't necessarily correspond to the actual treatment groups we're studying in our trial. Often it will, but sometimes it won't. So for example, some cancer trials, which evaluate kind of new drugs, allow patients in the control arm to switch to the intervention after disease progression. However, we might actually want to evaluate kind of the effect of the new drug on overall survival if patients aren't allowed to switch. For instance, if switching isn't really reflective of what happens in usual practice. So here, the protocol might allow switching, but in our estimand, so our question, we want to know what's the effect if participants weren't allowed to switch. The patient population, so this is just the population of patients targeted by the clinical question. And again, this won't necessarily always match the inclusion-exclusion criteria of the trial or even the analysis population of the trial. Often it will, but it won't. That might not necessarily be the case. So for example, for some trials, we might want to know what the effect of treatment is in patients who adhere to treatment. So here, our population might be the subset of patients defined by the inclusion-exclusion criteria who would adhere to either treatment group. So this is a subset of patients and not necessarily all patients in the trial. So the endpoint, so this is just the outcome measure for each patient. So I won't spend a lot of time talking about that. Population level summary measure. So this is just the kind of analysis method or the summary measure we're using to compare outcomes between the different treatment conditions. So for example, a risk ratio, odds ratio, difference in means, those sorts of things. And intercurrent events. So this is probably, I think, the most challenging aspect of Estimands. And what intercurrent events are these are post-randomization events which affect the interpretation or the occurrence of outcome data. So a lot of these have to do with kind of deviations to treatment. So things like patients stop taking treatment, patients don't even start taking treatment, patients switch from one treatment group to another, they get the wrong dose of treatment, or they get kind of a non-trial treatment, some sort of rescue medication. And in some trials, death can also act as an intercurrent event if the outcome data kind of doesn't exist after the point of death. So I'm going to talk just a bit about the 5 main strategies to address intercurrent events in your estimand. So the first one, and probably one of the most common ones, is a treatment policy strategy. And under this strategy, the intercurrent event is just considered part of treatment. So you might want to know the effect of the intervention as assigned, regardless of whether participants discontinue. So the idea here is that some patients are going to discontinue, and you want to kind of capture that part of the treatment effect. So it's sort of getting the effect of treatment as given in routine practice, where some patients might discontinue. One thing to note about a treatment policy strategy is it can't be used for kind of truncating intercurrent events. So things like death, which mean that outcome data after the intercurrent event no longer exist. And this is because there's just no kind of outcome to include in the summary measure. So treatment policy, this is usually estimated using intention to treat. So it's sort of sometimes called the intention to treat effect, but it's essentially getting at a treatment policy strategy. Hypothetical strategy. So this strategy, you consider the treatment effect in the hypothetical setting where the intercurrent event wouldn't occur. So for example, we want to know the effect of treatment in a hypothetical setting where participants don't discontinue treatment. So one thing to keep in mind when thinking about this sort of strategy is to think a little bit about how we might bring about that hypothetical scenario. So if in your trial participants are discontinuing treatment due to adverse events, if you estimate the treatment effect in the hypothetical setting where they don't discontinue, is that because you found a way to kind of make it so they don't have adverse events and they continue? Or is it that they are still having those adverse events due to treatment, but they're just continuing anyway? And if so, is that a particularly clinically relevant effect to be estimating? So the principal stratum strategy, here we look at the treatment effect in the principal stratum of patients, so the subset of patients for whom the intercurrent event wouldn't occur. So, for instance, we might be interested in the effect of the intervention in the subset of participants who wouldn't discontinue treatment under either treatment condition. One thing to keep in mind with principal stratum strategy is this is going to apply to an unknown subset of patients because we're never going to be able to know which patients kind of would adhere to treatment in both groups. Because in our trial, we obviously know whether patients adhere to treatment in their own group, but we'll never know whether they would have adhered in the other group. So this, we get a treatment effect which doesn't necessarily apply to all patients in our trial or all patients in our entire population. It's an unknown subset. So a composite strategy, here the intercurrent event is incorporated into the endpoint definition. So we essentially have a composite endpoint. So for example, if our outcome was death and the intercurrent event was treatment discontinuation, we would just change the outcome to death or discontinuation. So the usual caveats about composite outcomes apply here. And the while on treatment strategy, here the outcome or the endpoint prior to the intercurrent event is of interest. So here we'd be estimating the effect of the intervention while participants were still taking treatment. One thing to be aware of here is you might actually be comparing treatments under different time frames. So for instance, if patients in the intervention group discontinue treatment after a week due to kind of toxicity or adverse events, but in the placebo group, they continue taking treatment for 8 weeks, you might be comparing 8 weeks of placebo versus 1 week of intervention. And so you might be getting slightly different results between groups just because of the kind of difference in time frame. So a few things that are important to note with intercurrent events is that we can use different strategies for different intercurrent events. So for discontinuation of treatment, you might want to use a treatment policy strategy, whereas for treatment switching, you might want to use a hypothetical strategy, so the effect if the patient hadn't switched. Also, we can subdivide intercurrent events. So for example, treatment discontinuation could be split up into discontinuation due to adverse events and discontinuation for reasons other than adverse events. And then we might want to kind of handle each of these intercurrent events in using different strategies. So once we've chosen our estimand, we can then think about how to ensure study methods. So the study design, the kind of data we collect, and the statistical analysis, how we choose those to make sure that those allow us to kind of estimate that estimand. So ensure that those study objectives or study methods are aligned to our overall study objective. So I'm going to take you through a quick example using COVID-19. So if we imagine a kind of new trial set out to address a new intervention for patients hospitalized with COVID-19, one of the outcomes that we might be interested in, not necessarily as a primary outcome, but potentially as a secondary outcome, is the number of days that patients spend on a ventilator within a certain time frame, for example, within 30 days. So this outcome, it's an important indicator of patient health. So the longer you spend on a ventilator, kind of the worse your health, but also important for resource considerations. So the kind of fewer days you spend on a ventilator, the more ventilators we have available for other patients who need them. So the two intercurrent events we'll think about here are discontinuation of the intervention, or for example, missing kind of drug doses, and death. So I'm going to be talking about this from the perspective of our objective being kind of identifying the effect of the intervention if we introduced it into a healthcare system as part of routine practice. So if we adopted this new intervention into the NHS, how useful would it be? So it's a very kind of pragmatic question we're trying to answer here. So I'm going to start off talking about intercurrent events because I think these are probably the trickiest issue here. So I'll start off with death. And the big issue here is that patients who die earlier are potentially going to have fewer days on ventilators. So if you die on day 2, you can only have up to 2 days on a ventilator, whereas if you die on day 10, you can have up to 10 days on a ventilator. So this can make interventions with higher mortality rates appear more effective just because there are fewer days alive that you can be on a ventilator. So this is a bit of a problem. We don't want kind of ineffective interventions that have higher mortality rates appearing to be more effective for that reason. So different strategies to handle death as an intercurrent event. Well, we can't use treatment policy. It's not applicable here because there's no kind of relevant data to include after the patient dies. So we need to think of something else. A hypothetical strategy. So this would answer the question, what is the number of days a patient would spend on a ventilator if they didn't die? So in this situation, this is an impossible hypothetical scenario because, of course, some patients are going to die. So this doesn't really address the question of how kind of useful is this intervention if implemented into a healthcare system, because obviously it doesn't reflect real life. A principal stratum effect. So this is answering the question, how many extra days do you get on a ventilator, or how many days on a ventilator are you saved with a new intervention in the subset of patients who would be alive to the end of your study in both treatment groups. So again, this applies to an unknown subset of patients. So we don't know which set of patients would be alive at the end of the study under both treatments. And we also don't know how big of a subset or a subgroup this applies to. So we don't know whether this treatment effect applies to 90% of patients or 60% of patients. So if we want to know the effect of treatment if introduced into a kind of healthcare system, I think we probably want to know the effect for all patients rather than kind of an unknown subset of patients. So the while alive strategy, so this is just the comparing the number of days on a ventilator between treatment groups for the period of time that a patient is alive. So patients are on average alive for 2 days in the control group and 8 days in the intervention group. It's just looking at the average number of days spent alive on a ventilator between those groups. So you might get actually patients in the control group having fewer days just because on the ventilator, just because they're alive for not quite as long. So again, this can make ineffective treatments look better than they really are. And a composite strategy. So this actually, you essentially incorporate death as part of the outcome. And in this case, I think this actually works quite well because it allows us to make sure that death is a bad outcome. Rather than, while alive, where death can actually improve the outcome a little bit. So what we can do here is we can modify the outcome. So we can change it from the number of days spent on a ventilator within a certain time frame to the number of days patients spend alive without a ventilator. So here, any day that you're on a ventilator or dead is a kind of failure. And any day that you're alive without a ventilator is a success. And we just add up the number of days within a certain time frame to get our outcome. So discontinuation or missed doses. So I'm going to start off with discontinuation due to adverse events. So this is where the patient reacts badly to the treatment and needs to stop. So here, a treatment policy strategy is looking at the effect of the intervention regardless of whether patients discontinue or not. And this is probably what we want in a pragmatic trial where we're trying to identify the effect of treatment within a healthcare system, because some patients aren't going to be able to continue treatment. So it's important we capture that. But we might sometimes get discontinuation or missed doses for other reasons. So it might be that there are supply issues, for example, due to issues in supply chains during the pandemic, or it might be at the moment that actually the truck that's delivering the intervention might just be sat on the motorway without any petrol and can't get to the hospital, so patients don't get their drug at the moment. So this is a slightly different issue than kind of adverse events. So our question here is pragmatic. So we want to know, what is the effect of intervention if introduced into a healthcare system? So with this sort of question, we would normally use a treatment policy strategy to address kind of discontinuation. And this is estimated using intention to treat. And these are kind of linked, intention to treat, treatment policy with pragmatic questions. But this strategy, treatment policy, this is estimating or giving you the effect of the intervention given the fact that supply issues sometimes occur. Now, you might be an optimist. You might think, well, actually, I think, the reason for the supply issue is just a blip and it's all going to be resolved. And actually, in the future, we're not going to have those sorts of issues. And if this is the case, then actually a treatment policy strategy here isn't answering our question. It's answering the question of what's the effect of the intervention with these supply issues. But if we think the supply issues aren't going to happen in the future, then what we actually want here is a hypothetical strategy. So we want to know, what is the effect of the intervention in the hypothetical situation, which we hope is going to be a real situation quite soon, where those supply issues don't occur. Now, of course, we might not know whether these sorts of supply issues are going to continue. So it might be that we actually want to use both of these estimands and hope that they're not telling us very different things. So I'm just going to talk quickly about the population level summary measure. So this is kind of the strategy used to compare outcomes between the two different groups. So if our outcome is the number of days alive without a ventilator, this is often going to have a slightly odd distribution. So it's probably going to be a little bit skewed, and there's probably going to be a spike at 0 for patients who kind of died while on a ventilator and so didn't actually have any days off of a ventilator. So we might worry that a difference in means might not be an appropriate way to compare these groups. So some alternatives we might think about are a difference in medians or something like the Wilcoxon rank sum test. And I think often when we think about kind of population level summary measure, we often make this choice based on statistical reasons. So things about the statistical distribution or things like that. But it can be interesting or useful to look at this from an Estimands perspective. So how relevant is the question that each of these summary measures are answering? So a difference in medians. So this is just telling us essentially the difference in the midpoint of each distribution, so the median. So you kind of take the middle of one distribution, compare it to the middle of the other distribution. Now, one thing about this is, what if there are differences in other parts of the distribution apart from the middle? So, for example, if the intervention works best, or if the intervention only works in kind of the sickest participants. Now, this won't necessarily be picked up by a difference in medians if the treatment effect's only in the top 20 or 30% of patients. So it could be that actually a difference in medians doesn't really show any effect when actually there is kind of an effect just in a different part of the distribution. Similarly, a Wilcoxon rank sum test. So this actually answers the question, what is the probability that a randomly selected patient in the intervention group has a better outcome than a randomly selected patient in the control group? So it's basically saying, if I kind of randomly grabbed a patient in the intervention group, what are their chances that they're going to have a better outcome than someone in the control group? Now, one issue with this kind of measure is there's no sense of magnitude, or kind of not quite the sense of magnitude we might want to see. So for instance, one fewer kind of day alive without ventilation, or sorry, that should be one more day alive without ventilation, I think we'd probably feel a little bit differently to this compared to 5 days alive without ventilation, or even 10 days alive without ventilation. I think the magnitude in this outcome matters. And we don't really get this from Wilcoxon rank sum test. We just get a kind of probability, which doesn't necessarily directly correlate with the magnitude of difference between the number of days. Here, though, a difference in means. So this gives us, I think, a pretty easy to understand question, which is just, on average, how many additional days alive without a ventilator do you get with the intervention compared to control? So it's relatively easy to understand. It does give us that magnitude of benefit, the number of additional days. And unlike the median, it actually does capture the benefit of the intervention across the entire distribution. So, for example, if the benefit is kind of limited to the upper 20% of the distribution, the mean will capture that. It's obviously averaged over all participants, so it'll be kind of smaller than the benefit seen in that top 20%, but it will be there, unlike the median. So I won't say that a difference in means is necessarily the right answer. There's obviously some sort of value judgment based on this, but I think the difference in means actually does give a quite useful interpretation and a meaningful answer in this setting. And if we are worried about kind of statistical issues, is a difference in means, are we going to be able to get valid confidence intervals and p-values given the odd distribution? We can use other statistical methods to account for that, so things like bootstrap. So once we've chosen our estimands, we then need to think about how do we actually do the trial to make sure we're able to kind of estimate this. So the main consideration here, so if we're using a treatment policy strategy for adherence, we obviously need to continue to collect data on our outcome after the patient's experience discontinuation. So we can't stop data collection at the point of discontinuation. And when we're thinking about a hypothetical strategy for non-adherence or discontinuation due to supply issues, what this means is we're going to need to collect quite detailed data on patient adherence. So we need to know which patients kind of missed doses and when. And we also need to know the reasons for non-adherence so that we can separate out non-adherence due to issues such as adverse events versus non-adherence due to supply issues, which is the non-adherence we want to kind of tackle here. And we also need to think about collecting data to enable estimation of a hypothetical strategy, because in practice, this is a bit more complex than a treatment policy strategy. So we can implement this in various ways, but often we need to sort of account for post-randomization confounding. So we need to make sure that we capture data, post-randomization data on patient status that we can use to estimate this. So I'm not going to say too much on estimation. For treatment policy, we can usually just do this using intention to treat. So very straightforward, we just include all patients in the analysis according to their allocated treatment group. For hypothetical strategies, we can often do this using inverse probability weighting, where we essentially censor the patient or set their data to missing at the point of the deviation, and then use inverse probability weighting to kind of use other patients to make up for that. We can also use things like repeated measures mixed models, where we set patients' data to missing after the deviation, depending on the type of outcome, whether it's repeated or not. And for principal stratum treatment effects, we can also use things like instrumental variables or complier average causal effects, although I think now there are some other methods as well. So just to summarize a little bit, estimands can be helpful, I think, in randomized trials. If nothing else, just to clarify the question that we're trying to answer in our trial. So it's, I think, useful to get that clarity both for other people, so they can look at what the question means and is it relevant to them in their decision making. Also for ourselves, so that we can kind of ensure that study methods we're using address the right question. So we're using the right study design, collecting the right data, and choosing the right method of analysis. So if people are interested in learning a bit more about Estimands, the ICH United Addendum is a good place to start. So this is something written by the pharmaceutical industry in collaboration with drug regulators. And this sort of kicked off a lot of the interest in Estimands. There are also a few papers here. One is on Estimands for COVID trials, another Estimands for trials not about COVID, but which have been affected by COVID. So where COVID kind of actually acts as an intercurrent event here. There are lots of other good articles around as well. So yeah, I'm happy to answer any questions. And if people have questions down the road or kind of want any help implementing Estimands in their own trials, please do feel free to get in touch. So thank you very much for your time.
Thanks, Brennan. So while people are thinking of their questions, I wonder if you could go back to your previous slide, actually, because I think that was really reassuring to have that those sort of 3 points put there, actually. I have to say, I personally was terrified about this talk, so it's been really good to actually feel it isn't such a terrifying concept as perhaps us old dinosaurs had assumed that it might be. I think actually that first one, clarifying the question, is fantastic, actually, to have that right there at the top line. And I suppose that's one of the one things that all through my stats career, it's been, well, what is your research question? What is your research question? For goodness sake, tell me, what is your research question? So that's fantastic to find that. But actually more so, is it relevant to the stakeholders? That's I think something we're maybe getting better, and Graham may agree or not, because we're involving our stakeholders and patient participants much more, I suppose, in that way. So yeah, I think I do quite a lot with DAGs as well. So I suppose that's, sort of, again, it's trying to sort of think about more of the journey of that process as opposed to, let's just get this analysis done. So we've got a question from Graham, so that's nice. On you go, Graham.
Oh, hi everyone. Hi, Brennan. Now, I missed the start because it was I was doing an online parents' evening with the kids' teachers beforehand. So I'm multitasking, so I had the slides up, but I wasn't sure if you covered time to event outcomes. No, just because I find it simultaneously probably the easiest framework to get my head around Estimand, but also the most difficult. It's a paradox. And Bea might chip in here, because we had a recent example of this where some American colleagues were trying to replicate one of our sample size calculations for a time to event. And they're like, well, why haven't you expressed this as a hazard ratio? And I was thinking, well, that's the thing we want to estimate, but it's not really the question we want to answer. We want to answer, what's the difference in proportions at 3 years in this outcome, but acknowledging that it happens to some people sooner than 3 years and it happens to some people after 3 years. So we used those probabilities at 3 years to derive, using an exponential, we just assumed an exponential distribution to reverse engineer the hazard ratio. But the hazard ratio is not the quantity of interest. So, have we got the right approach there, or am I talking out my backside?
Oh, that's a big question that I don't think I have a good answer to, because I find time to event data and estimands really complicated in identifying the right question is. Because my feeling is I'm not sure the hazard ratio is the right question for myself. it's a bit difficult to interpret. I'm not sure it always gives you what you want, especially if the proportional hazards assumption doesn't hold. But then kind of identifying something better can be a little bit tricky because, of course, you could just say, I want, the difference in proportions at 3 years. But then you're kind of losing the time element of, well, if this is happening, these events are happening a bit earlier in one group than the other. That extra time they get, that might be beneficial. So rather than ramble on, I'm just going to say it's. I don't think anyone's kind of solved the time to event issue with Estimands yet. I think a lot of people are working on it. There's a lot of work being done, a lot of papers out there. I'm not sure I've seen anything that says this is the way to do it. I would say I don't think you're going wrong. I think in your example, I think kind of that makes sense to me. It's just a very difficult area. Sorry, that wasn't very helpful.
No, I think that's probably reassuring that there isn't. I think that's right, isn't it? That everything isn't necessarily a black and white answer. This is actually shades of grey. Just if people do have questions, to pop them also in the chat if they want to, if they don't want to actually sort of own up. But I see Beatrice has got a question, so on you go, Beatrice.
I guess I wanted to follow this up with something that I've wondered about a lot, and Brennan and I discussed it in the past, but I wondered for the full picture of involving stakeholders. So that second point about ensuring the question is relevant to stakeholders, because as you said at the start, Brennan, this is a topic that's even new to us statisticians and discussing things in these terms. Have you had success in discussing it with other stakeholders, or is it a work in progress with other trialists or other clinicians or patients?
To be honest, I mean, I don't actually do that many trials anymore, so I don't really get that much of an opportunity to kind of discuss these issues with stakeholders. So I don't know how easy this is. I mean, in the trials I have worked on, I mean, we have discussed these issues, not necessarily using the language of Estimands, but we have kind of talked about, well, some people are discontinuing treatment. How do we want to handle that? What does that mean? Those sorts of things. And I think my feeling is, I think it really depends on who you kind of are talking it through with and how easy it is you're able to make it to kind of explain what the underlying issue is. Kind of if you're phrasing it in terms of, statistical models, I think it might be a bit more of a challenging conversation with a clinician than if you're kind of getting at, what does this mean to the patient, that sort of thing. But I think we don't really have the answers yet on how best to have these discussions. And I think that's something that is quite important that we find out, because obviously we do want to make sure that, treatment effects or, trial results are relevant to stakeholders.
You're on mute, Lorna, but I'm assuming you're saying something like, go on then, you question hogging, bam.
Yeah, I was going to say, I thought that was a legacy hand, but that's okay.
No, it's not. No. I've got to dash, so I'm going to get greedy and ask a second and third question. And you might not have answers to these, Brennan. These are things, that maybe will require a little bit more consideration. But from my reading, most of the literature on this is around drug trials. And that's because the old methods were not great for making compounds look good for pharmaceutical companies. Now, I understand that. That's part and parcel of it. What I'm interested in is surgical trials where the intercurrent events happen after randomization but before treatment. And there's not treatment discontinuation, it's a crossover. And then that gets even more complicated in trials for surgery versus medicine, where you get crossover, you get discontinuation, but in the surgical arm, you could start on the medicine. So the intercurrent event is not discontinuation; it's starting something. So it's thinking about, and this isn't around about. I mean, it is around about Estimands, because I think that would help us clarify the methods. I struggle with just thinking about the Estimand in those scenarios. So yeah, it's maybe something for us to think about next time we meet face to face to have a proper conversation about. But you know of any literature would be great, but it all just seems to be focused on drug versus placebo or drug versus drug.
I don't know of any literature specific to surgical trials. You're absolutely right that most of the papers I've seen are specific to drug trials. And I think part of the reason for that is the ICH United addendum was for drug trials. And that's kind of the big thing that's kickstarted all of the talk about Estimands. I have seen I think the literature starting to branch out a little bit. I've seen, a paper for Estimands for patient-reported outcomes. So maybe people will get to surgery eventually, but it would be good to discuss because I think the kind of issues, like you said, in surgical trials are probably very different to drug trials. And so thinking through those issues in terms of Estimands, I think would be quite useful.
Yeah. Alison Avenel, I see you've got your hand up. Would you like to ask a question?
Hi, Brennan. That was a really good talk. I'm a clinician. I'm not a statistician. I'm just interested. So, what guidance at the moment does NICE have, particularly for oncology trials, in terms of Estimands?
I don't know the answer to that. I think, but I could be wrong, that I'm not sure there is necessarily direct guidance from NICE on Estimands at this point. My suspicion is Estimands haven't quite made it onto the radar of NICE. I don't want to say that for sure because that might not be the case, but that is my impression. Although it's very likely that NICE might have some guidance on methods they like to see in oncology trials in terms of how to handle treatment switching in the analysis, which is sort of getting at the Estimand, just not kind of directly, if you kind of get what I mean.
Okay, I think that's interesting because we do quite a lot of technology assessments of oncology treatment trials. So, yeah, that's interesting. Thank you.
Yes, I suppose we do a bit of the evidence synthesis, and it, as you say, it doesn't sort of feature too highly on as a topic area itself. But treatment switching is something that is very much sort of talked about.
Yeah, I suspect a lot of the kind of issues that come up in Estimands are on their radar and are talked about, but not necessarily framed in that way.
No, I think that's right. Yeah. Beatrice, I see you have another question.
Yeah, I'm going to be greedy like Graham, and I'm going to ask a different question, which is connected to what Alison just asked. So my impression, Brennan, is that clinical trials are not yet, particularly pragmatic ones, so not drug trials from the industry, are not particularly good at using the framework yet. And so do you think it is connected to stuff like NICE still didn't pick up on this, or maybe there's a lack of awareness? What do you think is stopping people from doing it?
I think my impression is it's mainly a lack of awareness. So, I mean, the ICH United addendum, which sort of kickstarted all of this, isn't that old. So I think the draft version came out in 2017 and it was only really finalized in 2019. So it is quite recent. I think it's now kind of made its way through the pharmaceutical industry, partly because they have to use it because the FDA kind of wants to see that in their kind of submissions. So they don't really have a choice, but there's no kind of comparable entity making academic or non-drug trials or trials that aren't being submitted to regulators do that. So I kind of think there's no real push for it in kind of non-pharmaceutical trials. So yeah, and just because all of the literature has been about pharmaceutical trials and published in journals targeted towards pharmaceutical trials, I think it just isn't really making its way around academic trials yet. I'm hoping that's starting to change. I mean, I think people are starting to become more aware of this. So hopefully, I can give a seminar in another 3 years and this will kind of be much more widely adopted.
I was going to suggest that I don't see that there's any of our health economics colleagues on the call, actually, and I think it's probably something that we should start to try and involve them in as well as ourselves. I think it would be a really interesting conversation, actually. might be something we could try and facilitate. Any other questions around? Not at the moment. We had, when Beatrice and I first talked about inviting you up, we had about 3 different sessions for you to do, actually. So, but we thought we'd just break you in slowly. I see there is another question from Alison. Quickly, yeah, go on.
It's an easy question. Can we get a recording of this?
Yes, it is being recorded. Yes,
great.
Yes,
thanks.
Yeah. So I was going to go on to say that, and we had also hoped that you might be able to come up to Aberdeen in person. So it is hopeful that at some stage we'll be able to do that, facilitate that, and then we'll get our 3 sessions from you. Because I think it's also something that would be really worthwhile having as almost at a public level, if you like, to our other colleagues, not statisticians, not health economics either, but just, like the likes of Alison. Thank you ever so much, Alison, for coming in. As a clinician, you're always very good at supporting us in these sort of things. But that's exactly, how to start to spread this better practice, I think, of thinking of how we should be doing our analyses and so on. So.
Well, yeah, I think one of the big things about Estimands is we do want kind of clinicians and patients to input into it. It's sort of a way to kind of dialogue between statisticians and everyone else, rather than the statistician going off and saying, I'm going to analyze the data this way.
This way, yeah, that's it. Yeah.
As much as a statistician, I enjoy kind of deciding that. It is good to make sure that
we should have those. Yes, I mean, ultimately that's what we want to do. But I think, we definitely have to be informed by what's important, and that comes from a multidisciplinary team. So that is our plan. In any case, I'm hoping that you'll perhaps come up to the RSS, which will be here in Aberdeen next year. So we're beginning to get excited about that. David, on that note, do you want to do any announcements? I think we've got a few. We'll have our AGM that we need to be thinking about relatively soon. And any other things on the horizon that we need to be thinking on?
No, there's nothing planned yet. Like I said, we've got no further talks or arranged yet, but I think we should probably try and fit one in before the end of the year, if possible.
Yeah. If anyone has any ideas, then please let us know. I think we've got still a few on our list, but it's just getting people to actually get in and do that. Okay, if there are no other questions, I'd just like to very much say thank you to, I'm going to do my applause clap. This is the worst part, isn't it? Is being able to get proper claps to our very deserving speakers. So it's been a pleasure to meet you, actually. Well, virtually. It would be great to see you in 3D at some stage, and we'll be able to arrange that at some stage. So thanks ever so much for taking the time, and a really nice, clear talk. So thank you ever so much for that. You took us very gently.
Well, thank you for having me.